Ah, Smart Water, now in a sleek can.
This feels cool, literally.
Perfect for social gatherings and on the go.
Should I start wearing turtlenecks?
One sip at a time, friend. Smart Water cans, for those with a taste for taste. Get yours today.
So, you just started using LinkedIn Premium. Now what? Well, on your premium company page, you noticed around 7.5 times more page engagement and 5 times more page views. Well done. And now, new clients are messaging you. All because you're using LinkedIn Premium, which helps you get the business growth you want. Think big, small business. Think big. Start your free trial at linkedin.com/premium small business. That's linkedin.com/premium small business.
This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. The podcast offers Category 1 CME through MyCares and Michigan State University. The links for the CME are in the show notes. This week, we're going to be discussing buprenorphine-naloxone versus buprenorphine alone in pregnancy. Sonya, how are you tonight?
I'm doing very well. How are you doing, John?
Good. Just living the dream, man.
Yeah, it's a little late, but it's a beautiful night. It feels like summer finally here in central Pennsylvania. Beautifully warm and sunny.
Yeah, it kind of goes from like normal to like hot and humid, and I'm not sure. You have a really nice office complex you're at. I'm like in an old house that's like put together, and it's like a bunch of like additions and stuff. And so like some of my rooms are like 98 degrees, and then the next room is like 32 degrees. And so, I feel like it's like some sort of perimenopausal simulator as I go from room to room throughout my clinic.
Nice. Yeah. My clinic is the opposite. We have no weather whatsoever. I'm in a basement with no windows, and it's always exactly 70 degrees, no matter what the climate is outside.
Yeah, I at least have a window. So that's nice next to my desk.
Lucky you. We got nothing.
Yeah.
I got some very sad desk plants that wish that they had sunlight.
It's hospice.
Yeah. These plants are survivors, though. Speaking of survivors, I really prepared like a total rant for our listeners tonight, and now I don't even know. I just don't even know what to say. I wanted to talk about Trump eliminating SAMHSA, the Substance Abuse and Mental Health Service Administration, or whatever it stands for. But I feel like by the time this episode airs, which will probably be in like 6 weeks, maybe it'll be reinstated. I kind of doubt it, but it reminds me, I live in Gettysburg, and they fired a bunch of the staff at the national park here. And then they realized that like the grass doesn't mow itself, because like that's who they fired. And then they had to hire everybody back to like mow stuff. So I don't know, maybe they'll realize that they actually do want these people who are working on these major problems, and it is a national priority to work with like substance abuse and mental health. But with these proposed plans to dismantle, much of our public health infrastructure, I'm just sort of depressed about it. It is a critical services for vulnerable people, children, pregnant and postpartum people who are homeless, people in the criminal justice system, programs to reduce overdoses, programs to support people at high risk for suicide. So I'll put a link to a Stat News article I read about this. But I just feel, I it's like decades of collective wisdom and experience where we work together as a country to fight these diseases now sort of going up in smoke. You can't. RFK told people they should just do their own research if they're looking for treatment on stuff. He said that about vaccines, but I mean, we really just want every individual to have to find their own treatment. We don't want to collectively produce programs, based on best practices. It's just like, good luck, everybody. Do your own research, find your own program, best of luck to you. So I don't know. It's kind of a downer, but that's what I've been thinking about. Maybe it'll be reinstated by the time this episode airs. And if it does, then I'm sorry for the bummer, everybody. And I'm glad that we made the right decision. But, I don't know. What do you think, John?
I mean, it's disappointing, right? I think the greatest irony of all is like, one thing I've always talked about is like, people in recovery hating on other people in recovery with how they recover, right? I know that some people really get triggered when I say that, but it's like the people that use medication or how like other people tell them they're not in recovery. And, the irony of this is, RFK Jr. is in recovery, right? And,
Yeah.
he's a 12-step member. He says he goes daily. Who knows what the truth is with that? But essentially, that's kind of part of his agenda, right? Is like pushing more faith-based and 12-step facilitation type programs. And at least that's what was at least one of the news releases I saw.
Yeah, residential programs, involuntary commitment to residential programs is like a favored method, from Trump and RFK Jr. Sounds expensive.
Yeah, I mean, I don't know. It also just it diminishes like the last 30 years of evolution in the field, right? We've gone to like a more individualized approach to meet the person where they're at, as opposed to like you do it my way or you die,
Right. Well,
essentially.
and I'm always surprised when I go to other states, like Pennsylvania has very strong sort of civil liberties and a real focus on individual rights and individual autonomy here in Pennsylvania that not every state shares. So the idea that we would increase the amount of sort of involuntary treatment we force people into is pretty shocking. Um, so we shall see. We shall see. We'll keep fighting the good fight. Anything in addiction news that struck you this week?
I just thought it was a mainstream article from New York Times, and it was basically titled "Fentanyl Deaths as Fentanyl Death Slows, Meth Comes for Maine." And I think it's an article that kind of highlights at least like a national level for like our lay press readers about I think what we see every day. It's basically as we've gotten better, and I hate to use better because I think there's still a lot of room for improvement, but with our treatment of kind of opioid use disorder, and we're starting to see some decrease in deaths and decrease in fentanyl overdoses, we're seeing rise of methamphetamine use in these communities. And this was specifically about Portland, Maine. And they were talking about how they've had like massive reductions in fentanyl overdoses. However, there's been a concurrent rise now in methamphetamine overdose. And actually, as a killer here, which we often think of stimulants not as healthy, but certainly they don't have quite the mortality rate as opioid used to, right? I mean, opioids are
Mhm.
a killer in their own outlier in that regard. And basically the article just highlighted just how difficult treating this is, right? I guess it's treatment from like a first contact standpoint. Patients with acute intoxication, they're not sleeping on a park bench, or they're not withdrawn or laying on their couch. They're often like agitated. They're coming into contact with law enforcement. They're often kind of not paranoid. They're in acute psychosis that's making it more difficult for first responders. They talk about how even at like the treatment clinics and the inpatient units, it's difficult for them because they're more agitated when they're presenting, so it makes more safety concerns. They talk about there's a lack of effective treatment options for this. And I was interested. I went on. This wasn't in the article, but I went on the main death registry, and it was the maindrugdata.org, and they were going through like how many deaths are involved with it, and I was really surprised. They talk about like in 33% of overdose deaths, methamphetamine was cited as the leading cause of death. That's kind of high.
Yeah, that is high.
Now, this is 1 month, but it's surprising to me. That's a lot. Although still they do mention that fentanyl use is still concurrent with many of these.
Yeah, I mean, it was surprising. I was talking to and now I can't remember where it was, so this is less useful, but another addiction doc somewhere training residents saying they, like, trained all these residents to do buprenorphine, but it was, like, a skill that suddenly, like, wasn't really needed so much. Like, their clinic didn't have any patients because everyone's, like, using methamphetamine now, somewhere on the West Coast, you know? So I think we've shifted, and it's kinda true. I see that I never thought I'd say that someone who's using a lot of fentanyl would be, like, socially functioning, but compared to people who are using a lot of methamphetamine, like, the people who are using fentanyl look like Boy Scouts, you know? Like, my patients who are struggling with methamphetamine are a lot of them are truly not able to function. They're just psychotic, they're hallucinating, they're paranoid, their brain is really elsewhere.
Yeah, I think in extremis, I think I've got a couple. I mean, I do the word functional methamphetamine user, but I do have like a couple people that I have one person that at Curlin, they come and see me every week, and every week I mean, I just keep talking to them. It's the same visit I've had now with them for 2 months every week. And it's basically they're just doing meth, living life, holding a job. They realize it's a problem. They're just not ready to shift. And I don't know, I guess they're just happy they're coming in, but
Yeah.
I'm just surprised that like I don't know what I still can't figure out what they're getting out of the visit or what they want from the visit or what I can do to help them.
They just like hanging out with you, man. Time well spent with Dr. Keenan.
My CRS, she got love her. She brings in like she always has something fun for the clinic, right? So she brings in like recipes or wellness activities or like flyers about like yoga or job fair. And so like I feel like every week it's like Kathy's grab bag. It's just so much more thoughtful than me, like, thinking about all the people like all the time when she's not here.
That's what keeps them coming back. Oh, yeah. So you ready to hear about my article?
Yeah, what do you
All right. So this is an article titled Comparative Safety of In Utero Exposure to Buprenorphine Combined with Naloxone versus Buprenorphine Alone, published in JAMA, September 2024. So, as we all know, addiction in pregnancy is common. Right now, about 8.2 out of 1,000 pregnancies is complicated by a substance use disorder. And, opioid use disorder is common, and we use both buprenorphine and methadone in pregnant people, but buprenorphine has become more common both due to ease of access and possibly better outcomes compared to methadone. Also in the US, buprenorphine is often combined with naloxone as an abuse deterrent, meaning that it's supposed to keep you from abusing the medicine, like taking it in a way other than how it's prescribed. Although the efficacy of this strategy is unproven, they haven't actually shown that buprenorphine naloxone is, somehow safer than buprenorphine alone. Um, but like many things, naloxone hasn't been officially tested in pregnancy. And so in the past, guidelines have recommended that pregnant people be switched from the buprenorphine to buprenorphine alone. So, despite this lack of safety data, many, many pregnant people and their fetuses have been exposed to naloxone without apparent increase in adverse outcomes. People are on medication, they get pregnant, they don't know they're pregnant, time goes on, and they haven't really shown any adverse fetal outcomes to these accidental exposures. So, the clinical question is to assess the risk of adverse neonatal and maternal outcomes associated with prenatal exposure to buprenorphine naloxone compared with buprenorphine alone. So before we go any further, John, when you have someone who's pregnant and they've been taking buprenorphine naloxone or buprenorphine alone, what do you do with the medicine? Do you switch it? Do you keep it the same? How do you counsel people?
I typically counsel them that I guess first of all, we don't need to make any drastic changes today, but continue their medication and that we can either switch them over to the mono product, although at least most of the recent data that I've seen in the past couple of years shows that there's just no real difference between the two that I've read to date before today. And so I've kind of let them choose.
Okay. Yeah, me too. Me too. I mean, a while ago, I would say that the guidelines say we should switch to the mono product, but you don't have to. But if you don't care, or you want to, then let's switch. But I also have stopped sort of even recommending that in the last few years. So this paper really, really addresses that question head on. So who was in this study? It included dyads, the pregnant person plus their fetus, so 2 patients per unit, let's just say. And it included 9,537 pairs. They had to screen 2.5 million pregnant people to get this 10,000 for this study. So tons and tons of people screened. It was from a Medicaid analytic extract, Transform Medicaid Statistical Information System analytic file. So giant Medicaid database. You had to be between the ages of 12 and 55. You had to have had Medicaid for the duration of your pregnancy. And you had to have been exposed to buprenorphine, not taken methadone, and not have any other major fetal congenital anomalies. So who was excluded? If you had a chromosomal anomaly, pregnancies with first trimester exposure to known teratogens, or people who got methadone for opioid use disorder were excluded. So if you were already at high risk for birth defects or on methadone, you were not in this study. You were in the study if you were pregnant on Medicaid and were exposed to buprenorphine. So this study, participants on average were age 28, 88% were white, 25% used tobacco, 70% had opioid use disorder, diagnosed anyway. And given that all of them were exposed to buprenorphine, it was probably higher than 70%. 35% were on antidepressants, 14% on some kind of suspected teratogen, and but not a known teratogen. 26% were on prescription opioids, and 15% received adequate prenatal care, which is kind of sad. Adequate prenatal care just means you hit the majority of your recommended prenatal visits, and only 15% of people in this population
It's
did. Yeah,
heartbreaking.
it's sad. I mean, there's a lot of prenatal visits there, but it's sad that such a small percentage of people made it to the majority of them. The harmful event was receiving buprenorphine naloxone, and they compared it to people who received buprenorphine alone or switched to buprenorphine alone in the first trimester, which is kind of what mirrors clinical practice. The outcomes were major congenital malformation in the fetus, and cardiac malformations as a secondary, sort of a second primary outcome. And they did that just because cardiac is the most common class of malformations and a leading cause of congenital malformation associated infant morbidity and mortality. They also looked at a bunch of other outcomes, including other organ system malformations. So divided by organ system, abdominal, CNS, eyes, ears, genital, limb, etc. They looked at neonatal outcomes. So low birth weight, neonatal abstinence syndrome, NICU admission, preterm birth, respiratory symptoms, and small for gestational age. And then they looked at a few maternal outcomes, so cesarean delivery and severe maternal morbidity. So again, just to summarize, basically, where people who are exposed to buprenorphine naloxone combo have different outcomes at birth compared to people who were exposed to buprenorphine alone, and the major outcome were congenital malformations and neonatal abstinence syndrome and some neonatal outcomes. So, John, what did you think of the clinical question?
I mean, it seems very much like OB-centric, right? We're kind of looking at congenital malformations as kind of a primary outcome, cardiac malformations. I mean, I know they're pretty rare to begin with. So I'm interested to see like what they say. I'm kind of most interested in kind of the lower ones like low birth weight, NAS, NICU admissions, preterm birth. And maybe that's just because like I take care of the baby
Right,
after it's born, not know so much the mom. But I like the mix of outcomes for the dyad, right?
right. Yeah. So let's talk about validity. I want to just spend a moment on the statistical analysis, not because I relish talking about it, but because it was a huge part of this paper and I didn't want to just skip it. So they really worked hard to adjust for confounders because the problem with a study like this is that it's not randomized, is that people who receive buprenorphine naloxone combo may not be the same as people who receive naloxone alone at baseline. Any number of reasons those two groups could be different that we could think of in our brains, but it's just they're just not the same at baseline. And so you have to somehow adjust your data for that so that you can make a kind of fair comparison. So they tried it in a bunch of ways. One is they did these sort of adjustments for different confounders. They looked at so many confounders, so demographic characteristics like age and race. They looked at markers of opioid use disorder, severity, and history, like had you been to the ED, hospitalized, what was your buprenorphine dose? They looked at other substance use, other comorbid mental and physical health disorders, other medications, especially those that contribute to neonatal abstinence syndrome, like antidepressants, benzodiazepines, healthcare utilization metrics, and then socioeconomic status kind of proxies like education, metropolitan versus urban versus rural, poverty, unemployment. So they just looked at all these different potential confounders and tried to adjust for them. And then after they made these adjustments, they kind of balanced the two groups, which is a way of making the two groups similar and made sure the mean difference in all these different characteristics was less than 10%. They did this using a technique called propensity scores. So each individual in the study is given a propensity score, meaning how likely are they to be in one group or another based on their sort of baseline characteristics. And then they did this sort of additional statistical technique called propensity score overlap weighting. which basically estimates the treatment effect in individuals if there's an equal likelihood of them being in either group. So their propensity score was kind of close to the middle in terms of whether they would have been more likely to be in one group versus the other. And then there was a few additional estimates. I don't feel super qualified to discuss them, but they are described in the paper, so I hope that people will take a look. But again, they were done to reduce bias and confounding. And so this was a big part of this paper, really trying to reduce the confounding in this non-randomized trial. Finally, they did a bunch of sensitivity analyses. I call these the what ifs. What if you restrict your data or your population to a certain subset? Do you still see the same outcome? And if you do a bunch of pre-specified sensitivity analyses and you get the same result in these different pre-specified subgroups, it increases the sort of robustness of your findings. So they looked at people who just received adequate prenatal care. They looked at people who just had a live birth. They looked at people who without a diagnosis at baseline of opioid use disorder, those kinds of subgroups. So they just did all this stuff. And then finally, they focused on the risk ratios and confidence intervals rather than p-values. So rather than just say it is statistically significant or it's not based on your arbitrary p-value, they just said, here's the average and here's the confidence interval. So a lot of interesting statistics in this paper. So just to, and I encourage anybody who wants to take a look at it. I want to talk about a few more strengths. The first strength is that this study really adds, I feel, important data to the literature. Prior to this, only small studies have been done looking at buprenorphine-naloxone compared to buprenorphine in pregnancy. This study basically increased the number of, maternal fetal dyads by about tenfold, allowing for much more precise estimates regarding the risks evaluated in these prior studies, as well as power to consider a broader range of the relevant safety endpoints. This population was highly generalizable since most pregnant people with opioid use disorder are on Medicaid, so it's a very representative population. They did all this work to adjust for the differences of the groups at baseline, which I appreciate. They measured the exposures and the outcomes the same way in both groups, and the outcomes I thought were really clinically relevant. These are the big ones: fetal congenital anomalies and neonatal abstinence syndrome. That's what most pregnant people are interested in when they have to consider how their pregnancy is going to progress with their opioid use disorder. I thought follow-up was long enough. It answered the basic clinical question. I mean, I think there could be subtle long-term adverse outcomes to the fetus, not noticed in the first month of life, but the study wasn't really set up for that. And finally, funding was unlikely to cause bias. It was funded by NIDA. So a lot of strengths in this study. A few limitations: not blinded, not randomized, not controlled. Always possible that they're unmeasured confounders, no matter how many statistics you do. And then, like other large database studies, they're really dependent on coding accuracy. So what is coded might not actually have happened. They did try to assess for this, and at least they determined that the coding was equally accurate or equally inaccurate in the two groups. And the other thing that was a limitation is they didn't assess opioid use disorder outcomes in the birthing people. They merely assessed these outcomes related to the birth itself, but they never said whether people who are switched to a different product had better or worse outcomes in terms of their opioid use disorder. So if you're trying to help a person assess the risks and benefits of switching versus staying on the same product, you have to know how it will work for their opioid use disorder as well. And that was not assessed in this study. So what did you think, John? Did you think this was a valid study?
Yeah, it's interesting. Is the reason that the issues where they didn't track the birthing persons, like their recovery-related outcomes, is that because that just wasn't part of the database?
I mean, maybe they could have gotten something out of the database. I guess they could have looked at like overdose rates or hospitalizations for opioid use disorder. There's some sort of high-level markers. I think it just wasn't the question they were asking. They were really truly looking at safety to the fetus and of the birth process itself.
Yeah, I think it's an interesting question. I think these are very I feel like our classic clinician related outcomes, right? Like birth mode, timing, kind of congenital malformations, neonatal abstinence syndrome, duration.
Right.
So I think it compares to a lot what we've looked at with this before.
Yeah, and it's definitely something that the pregnant people I work with are interested in. They want to know, will it hurt the fetus, and is the baby going to have neonatal abstinence syndrome? You know? Those are their two big questions usually. So I do think it's a clinically relevant outcome. But, you know, I mean, people are willing to make sacrifices for their pregnancy, but then a lot of people also not. Like if I said, well, you'll be at high risk for relapsing onto, fentanyl, that's a hard sell for people, so it would be nice to have that piece of information as well.
Yeah.
All right, ready for the results?
Yeah, let's do it.
Bottom line, both neonatal and maternal outcomes were either the same or better through treatment with the combination buprenorphine-naloxone compared to buprenorphine alone. That's the bottom line. Better or the same. There was massive data in this paper, massive data tables, so many forest plots, so many sensitivity analyses. This is audio, so I can't show them all to you. But in general, if there was a difference between the two groups, it was small, or the confidence intervals crossed the null, meaning that it wasn't statistically significant. And when there was a difference, the buprenorphine-naloxone combo was better than buprenorphine alone. So let's talk about some specific numbers and some of the outcomes. I'm just going to talk about the adjusted outcomes for the main, the adjusted numbers for the main outcomes. So the biggest one is overall congenital malformations. So in the buprenorphine naloxone and the buprenorphine alone groups, it was about 5% for both, and the confidence interval crossed the null, crossed 1. So almost identical. In terms of cardiac malformations, 1.4 and 1.3%. Again, confidence interval crossed 1. They were almost the same. Neonatal abstinence syndrome in the fetuses that were exposed to buprenorphine naloxone alone, or buprenorphine naloxone combo, it was 37.7%. And those that were exposed to buprenorphine alone, it was 55.9%. So a really big difference there. In terms of NICU admission, and this would track with neonatal abstinence syndrome, about 30.6% of the fetuses exposed to the combo were in the NICU, and 35% of the fetuses exposed to the buprenorphine mono product had to go to the NICU. So again, a significant difference. And those are the big outcomes. As I said, there were so many forest plots in the paper, but all of the sensitivity analyses, all the subgroups had the same conclusion, either slightly better or the same to go on the buprenorphine naloxone combo. So will these results help me in patient care? I think so. These patients are similar to my patients. The outcomes, I think, are clinically relevant. If we have to assess benefits versus risks, like we said, it seems like the benefit of switching to buprenorphine naloxone or being on buprenorphine naloxone is either there's no benefit or either it's the same or slightly better. What they don't assess is the risk to the pregnant person. It sort of treats the pregnant person as a vessel taking care of the baby, but doesn't really get into how they might feel during the process of the pregnancy if they have to switch medications. So I can't really do a full risk-benefit analysis. But in terms of these outcomes, the number needed to harm, so if you switch from buprenorphine naloxone to buprenorphine alone, and you look at overall adjusted congenital malformations, the number needed to harm is about 400, meaning you would save one major congenital malformation if you got 400 people from the mono product to the combo product. For prevention of neonatal abstinence syndrome, the number needed to harm is about 8. So 8 women would have to be on the, if 8 women were on the buprenorphine mono product, there would be one additional case of neonatal abstinence syndrome. So, I feel those numbers are pretty relevant, but I think this study will change my practice because basically now, if a patient asks me which is better, I would say with confidence that the buprenorphine naloxone combo is safer in pregnancy. But I would say personally, if a switch would destabilize her treatment, I would stay on the buprenorphine alone because the difference is not that great. And neonatal abstinence syndrome, while not a outcome that any of us want, it is a temporary condition. It's often easily treatable. We use eat, sleep, console at our hospital. Patients are often very satisfied with that as a treatment modality. And so I would counsel people to switch if they were able to, if they asked, as long as it wouldn't destabilize them. How about you?
Yeah, it's an interesting question. I think I want to be less. I don't know. I mean, it's tough. I'm not gonna be like I'm not only gonna give you the combination product now, but I think that if a patient asks to switch because of safety, I think which is probably the most common reason that this comes up, right? I mean, patients know this. I guess at this point we can call it the old wives' tale that the mono product is the only one that's safe in pregnancy. So I think I could use this information to tell them that if they're content with their current treatment, we can leave you on the combination product. I think that the group I have on the mono product, they're there for a very specific reason. It's a small subgroup to begin with. I don't think they're going to have much interest in switching over with this information, to be honest.
Well, right. I mean, given the pharmaceutical situation in our area, I can only get pharmacies to fill the prescriptions for the buprenorphine mono product if there's been some sort of adverse effect from the combination product, like an allergy to the naloxone or significant adverse effect. Like, we have to document that before pharmacies will even fill prescriptions for the mono product for non-pregnant women. So most people have had some kind of problem with the mono product, and that's why they switched in the first place. I mean, had some problem with the combo product, and that's why they switched. And I don't see them wanting to switch back, giving you a whole pregnancy of like migraines or nausea or whatever.
Yeah. It's interesting. It kind of points back to this kind of underlying concept about like the absorption of the naloxone component, right? I think that like more and more, this mantra that if you take it correctly, you're getting no naloxone. I think that's not true. I think there is some variability of absorption here from person to person. They've had studies about serum levels, and I feel like that's, I mean, the NAS, right, outcome, right? That's definitely just, you're getting more buprenorphine, right? So you're getting kind of, it's the absorption level of the naloxone that's affecting that.
Yeah.
It's interesting.
Yeah. I mean, anyone who does like a comprehensive urine drug screen that includes quantitative levels of buprenorphine and naloxone and norbuprenorphine knows that there is naloxone in people's urine. Like, you are absorbing it, and that level's variable based on the patients. But like, I've had so many people tell me that they were having some kind of adverse effect, either headaches or nausea are the two big ones, to the buprenorphine naloxone combo that resolved when they switched. And the fact that I don't really see a lot of secondary gain to having the mono product. There's a theory that it's somehow abusable, but I'm not really seeing that. So I certainly don't mind switching people if I can get it covered.
Yeah, I've kind of like, well, I feel like it. You're right. I don't see some big gain with being on the product. I feel like if you're in treatment, you're in treatment. I'm just happy about that.
Yeah. Yeah. And I'm happy you don't have headaches every day.
Yeah. Well, thank you so much for that article. I think it was a very interesting discussion there.
Yeah, and I think this is going to be like a seminal article. I think this is like, we already kind of knew this was the truth from a lot of sort of smaller papers on this topic, but this is, like I said, this increases the number of sort of data points tenfold. And I think this will be kind of the definitive word on this, given that we're not going to have a randomized controlled trial ever.
Yeah. Well, thanks for that, Sonya. Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from My Cares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles that we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.